Hi everyone, I'm Dane Zappa. For those of you who I haven't met yet, I'm looking forward to working with you, and for those of you who know me, thanks for taking the time to watch this video. Today, we're talking about how to order the right level of care every time. This is a 5-minute lecture series where I'm going to go in depth into key diagnoses where there are opportunities to support our fantastic case management team. First, let's talk about why, because what's the how without the why? Reason number one, it's the right thing for the patient. As we all well know, many of our patients, once stabilized, still cannot go straight home for a multitude of social reasons. Those patients need placement. Entering in the wrong level of care on a patient can cause us to lose a midnight, which is the time frame by which Medicare measures length of stay. This can increase length of stay and causes issues in discharge planning, ties up a bed longer than necessary, and further exposes the patient to complications such as hospital-acquired infections. The second reason I think we can all understand, and that's that it affects the bottom line. While none of us are in this field just to make money, and let's be honest, we could have just gone into day trading if we wanted it to be easy, finances are also not unimportant. Selecting an inappropriately low level of care can then delay collections and ultimately may end up with less reimbursement. So now that we understand the why, let's talk about how. October is GI Bleed Month. That's right. This is one of our greatest level of care opportunities, and so will be our first target. OBS or inpatient? Well, the answer may surprise you. Observation criteria is met with a history of recent bleeding such as coffee ground emesis or hematemesis. These patients must present with the hemoglobin greater than 7, and you have to administer either a liter of fluids IV or have given blood products prior to the decision to admit. This is for observation. For inpatient criteria, you meet this with an active or ongoing GI bleed, for example, a positive Hemoccult with gross melena, hemoglobin less than 7, and either blood products or fluids provided prior to the decision to admit. The most important differentiating pieces between the two is seen with H&H, how the bleeding is defined by documentation, and in either case, you have to give a liter of fluids or blood prior to decision to admit. It's pretty straightforward, right? And where did I get this information from anyway? From the badge buddies that we all have. If you need one and don't have it, reach out to your leaders and they will get you one. You can see that mine has seen some wear and tear here and there. And that's it. See? Pretty painless, and we have a lot to gain by getting this right. So make sure to engage your admitting partner in discussion about level of care. Remember, October is GI Bleed Month, so fire up the blood warmers and let's make sure that we get the level of care right every time. Thanks for watching.